Thanks for the opportunity. It's a fun meeting. I feel like we're really at the vanguard here, and I appreciate being invited. A lot of technologies have been thrown at me in the last hour, and I probably speak for most of us, so I'll try to just put this in perspective and sort of describe it. So TULSA is transurethral ultrasound prostate ablation. That's the acronym. It's MRI guided. You'll see this depiction of the transducer going intraurethrally. It's got 10 different transducers then, which can emanate high-intensity ultrasound, not focal, but high-intensity. And what you're getting on that image there is an actually sweep, in this case counterclockwise, across the gland. No energy in the rectum, a sweeping ultrasound with continuous rotation with a little servo motor, which can treat prostates of various sizes. Rectum is cooled and urethra is cooled, as you'll see on the thermometry image by that blue dot. These are measures of temperature in real time, okay, which is exactly what Dr. Natarajan was contrasting with the system he's bringing into the office. This really is in bore. I mean, this is a completely anesthetized patient, but you get outstanding temperature feedback, precision treatment, and an algorithm that compensates for changes of temperature during treatment, and essentially no motion of the patient. This is just a sagittal view of the probe going into the urethra, placed cystoscopically by urologist, a rectal cooling balloon, and then the transducers, which you can activate depending on the length of the prostate when you decide to do the contouring. On the top here, you actually see the treatment planning, which is basically a radiologist and or urologist together working on contouring the outline of the prostate for whole gland treatment. In this case, focal we can discuss in a little bit. And then you can see the patient is sort of in bore as one decides to activate the ablation. And this is, again, is a high-intensity ultrasound sweep of the prostate from apex to base, or really from wherever you decide to go. Contoured, you can see in some areas slightly outside the prostate if you want to really get a bulge in the capsule, contoured inside the prostate if you want to stay within it, and then an MRI confirmed fairly impressive ablation on the bottom. So Profound Medical, who sponsored this pivotal study called TULSA Pro Ablation Clinical Trial, or TACT, performed this 115-patient study at 13 clinical sites in 5 countries. I was an investigator, and presumably there were others in this room as well. This was a low and intermediate risk patient population. This was a whole gland ablation, and the primary endpoints were pre-specified by the FDA in consulting with the company, and they included safety and efficacy. But to urologists, the secondary endpoint of prostate biopsy outcomes at 1 year, I think, are particularly interesting, and so we'll go over that. But again, a mixed, low, high volume population, or a low or a clinically significant grade group 2 population. Safety was definitely shown, no rectal injuries, no grade 4 higher events, and this is all the SAEs. You can see essentially with overlapping patients, a lot of these just occurred in basically one patient, and infection, fairly minor overall and very treatable. The PSA primary efficacy endpoint was relatively met. They were looking, FDA wanted a reduction of PSA of more than 75%, and in this case, PSAs went essentially to a median of 0.34 in all these cancer patients with IQR there. And prostate volume, which is really the impressive thing, completely ablated. Essentially, this is a gland that went on average from 37 grams to 3 grams at 1 year MRI. So you just don't see a prostate left. How do you biopsy a prostate at 1 year when there's just a urethra? Well, I think if anything, that would probably overestimate, the density of sampling at least would be very high, and we were instructed to put, at least 10 needles into the area. 111 patients agreed to that, and these are the outcomes. You see the baseline graph on top, with the dark being the clinically significant grade group 2 disease, and at 12 months, essentially no evidence of disease in about 2/3 of the patients, and then another 15% had basically insignificant small SNPs of grade group 1. Still some clinically significant disease in the teens around grade group 2, and a little bit of high volume grade group 1. So in terms of, for a whole gland study, obviously one thinks of whole gland as something that will provide unfortunately, radical outcomes in terms of problems with ED, urethral stricture, urinary incontinence, et cetera, perhaps GI toxicity. And the TULSA, results are on the left compared to a literature review of prostatectomy radiation and whole gland HIFU. And essentially, this was extremely well tolerated. I myself had 7 patients in this study, transient erectile dysfunction. The 23% rate at 1 year is dysfunction that can be treated with medications. No patient had any more severe ED. The incontinence was, again, people wore a pad for a few months, perhaps for occasional stress incontinence. That seemed to resolve by year 1, and the stricture rate was extremely low. So it's sort of a sea change if this holds up. And it definitely is a very well-controlled ablation, if that's what we're discussing here today. So I think we agree that at least at 1 year, we have an acceptable disease control. Patients could be retreated by radiation, for example. There's been salvage prostatectomies done in some of these patients, which apparently have gone well. I think the safety profile seems excellent compared to other whole gland options. And the company recently received FDA approval in 2019, August, based on this pivotal study. But there are no billing codes yet, and that's kind of the next hurdle, of course. Now, this platform truly, I think, is ideal for customizable focal ablations, because as you saw, the sweep, you can actually just sweep from, say 100 degrees to 140, or 270 to 360, or base to mid, or mid to apex. There's no reason one has to perform this in a whole gland fashion. And there have been 2 treat and resect studies demonstrating the feasibility of this with good ablation precision. 1 same-day treat and resect from Canada, and 1 3-week treat and resect from Finland, where this is ongoing. And there's a high-volume center in Germany doing a lot of these focal ablations. We don't have a lot of data on that to show because, again, it's not in use in the US yet, but I think that is kind of the next movement. So in conclusion, I think, the study showed that whole gland ablation is possible with thermometry, with, extreme care to not get outside of a margin, but to the margin. And preliminary results suggest this could be a great modality for focal ablation. I think this society would be a great place to design studies using a technique like this. Open to questions if there's any time.
Thank you very much.